Good morning. Thank you for the invitation to share our work with you. My name is Iman. I'm a research fellow at Case Western Reserve University in the Department of Dermatology. I will be presenting the results of our recent analysis of fungal and bacterial microbiomes associated psoriasis patient endotypes. Let's start with some basic terminology that's relevant to our study goals. We are all familiar with phenotype. Our phenotype is psoriasis, with its varying degrees of severity. Second is endotype, is a subtype of condition that can be defined by distinct functional or pathobiological mechanisms. In our study, we investigated the pathobiological influence of the gut and skin microbiomes, referred to as entero or cutaneotypes, based upon their site of origin. Previous work has examined the gut-associated microbiome in psoriasis patients. However, only one group has advanced the concept of specific bacterial enterotypes in psoriasis patients. Kodner and colleagues identified 3 enterotypes based on the predominant phylum in the gut of psoriatics, comprised of Bacteroides, Brevotella, and Ruminococcus, respectively. Interestingly, higher frequency of bacterial translocation and more inflammation was associated with enterotype 2. In terms of microbiome on the skin of psoriasis patients, or cutaneotype, Alexenico and colleagues identified specific psoriatic cutaneotypes based on predominant bacterial phyla in psoriatic plaques. In these 2 cutaneotypes, group 2 was more prevalent in psoriatic plaques versus normal skin. The aim of our study was to characterize entero and cutaneotypes that incorporate bacterial and fungal organisms, so-called micro and microbiome, using unsupervised hierarchical clustering and an examination of potential correlations with other metabolic and physiologic markers. Our study enrolled psoriasis patients and healthy control. We collected both gut and skin swabs. Psoriasis skin swabs included lesional and non-lesional sites. In addition to bacterial micro and fungal microbiome data, we also collected additional relevant clinical features, such as treatment data, psoriasis severity indices, comorbidity assessment, and laboratory measurements, including serum inflammatory markers, peripheral blood flow cytometry, and metabolic profiles. At the level of bacterial microbiome, we found that psoriasis treatment using biologics significantly altered the gut microbiome composition compared to untreated psoriasis patients as well as healthy control. At microscopic view, it's clear that changes in the proportions between the predominant phyla vary based on biologic treatment. For example, Bacteroidetes, which represents 33% of control microbiome, was only 9% of the microbiome among untreated psoriasis patients. However, following biologic therapy, Bacteroidetes returns to approximately 41% abundance. Statistical analysis of Bacteroidetes abundance demonstrates no significant difference between control and untreated psoriatic patients, but a significant increase in abundance in patients treated with biologic therapy compared to untreated is observed. Biologic therapy also reduced the abundance of Firmicutes in treated psoriasis patients compared to untreated patients and healthy control subjects. Similarly, abundance of Actinobacteria and Fibrobacteria were also significantly altered in patients receiving biologic therapy. Previous studies identified subject enterotypes simply using the predominant phylum. Our study goes a taxon further and has assessed the 50 most abundant genera in psoriasis patient stool samples. We generated several heat maps to visualize our analysis of skin and stool samples. The heat maps represent the level of abundance of the bacteria or fungi, which is identified by the blue to red color differences. The layout of the heat maps are constructed with patients in column and bacterial genera in rows. Additionally, demographic information about the subjects, such as race, age, sex, are shown at the top of the heat map. Heat maps were assembled using unsupervised hierarchical clustering and delineate in this example two visible enterotypes. Note that in this heat map, control subjects were included and are predominant in enterotype A versus enterotype B, where only one control individual appears. Based on abundance of organisms, enterotype A was identified with decrease in gram-negative genera such as Salmonella, Enterobacter, and Shigella, and higher abundance of gram-positives such as Ruminococcus and Roseborrhea. The opposite was observed in enterotype B. Interestingly, the involved gram-negative genera seen are frequently described as pro-inflammatory, and conversely, the gram-positives are generally considered anti-inflammatory, which makes sense given the number of control subjects within enterotype A. When we examine the abundance of organisms in the psoriatic plaque skin microbiome, we again appreciate the emergence of two distinct cutaneotypes. The distinction characteristic between cutaneotype A and cutaneotype B is a higher abundance of gram-negative genera, such as Serratia, Klebsiella, E. coli, in cutaneotype A compared to cutaneotype B, where abundance of gram-negative organisms are decreased. Conversely, both cutaneotype A and cutaneotype B exhibit decreased abundance of gram-positive organisms. Looking at uninvolved psoriasis skin in the context of its fungal microbiome, we see the emergence of two cutaneotypes associated with the highest abundance of fungal species in non-lesional psoriatic skin. This is the first report to our knowledge identifying microbiome cutaneotypes in psoriasis patients. The most impactful characteristic is the higher abundance of opportunistic pathogens associated with cutaneotype A, and the greater prevalence of moles with cutaneotype B. The fungal cutaneotype comparison also highlights several statistically significant differences, which align with observed clinical outcomes and inflammatory cell responses. More severe phenotype was observed with cutaneotype A, as evidenced by higher BASI and BSA. We of course appreciate at the moment that subject number is low, and more comparators will need to be evaluated in subsequent studies. The more severe phenotype in cutaneotype A is upheld further by statistically significant increase in neutrophils and monocytes, and concurrent decrease in lymphocytes. By comparison, cutaneotype B was more associated with metabolic derangement, seen in conjunction with more treatment failure. More specifically, the metabolic picture of cutaneotype B shows poor glycemic control and dyslipidemic profile as evidenced by increase in VLDL and triglyceride, and a decrease in HDL. Interestingly, cutaneotype B was also associated with a significant increase in monocyte platelet aggregates, which is a strong marker of cardiovascular and peripheral arterial diseases. Thus, in conclusion, we show that treatment of psoriasis patients with biologic therapeutics statistically alters the abundance of distinct gut microbes. Gut and skin, bacterial and fungal microbiomes identify distinct enterotype and cutaneotype psoriasis patients. Distinct patterns of laboratory and clinical measures are associated with respective enterotypes and cutaneotypes, with significant differences in clinical and laboratory features among subjects grouped by fungal cutaneotype. Finally, I would like to acknowledge the participants in our court study cohort and the financial support granted through the National Institute of Arthritis, Musculoskeletal, and Skin Diseases, as well as National Psoriasis Foundation and Bordeaux Family Center for Psoriasis. Thank you for your attention.